Okay, so thank you for joining me today. We are going to go over Skills Lab Day 1, the antepartum period. And I need to give you a little disclaimer. I want you to please be advised that this PowerPoint has sensitive content and photographs, so viewer discretion is advised, meaning don't be watching this around your children and little ones. Okay? So, what we're going to go over today is reproductive health, pregnancy nutrition, and electronic fetal monitoring. So, when it comes to reproductive health, we're going to talk a little bit about clinical breast examination by the provider and self-exam instructions, pelvic exam, and birth control. So, starting with the breast exam, we used to have a nice big place in our 4th edition textbook, box 6.1. But our current 5th edition textbook just really discusses breast cancer screening on page 190 through 191 and stresses that our clients need to be breast aware. But I'm just going to go over how a breast examination is performed by a provider to assess the breast for abnormal findings. So the provider will start with inspection. The provider is going to start with the patient sitting on the side of the bed with both arms resting at the sides. The breasts are going to be looked at to look at size, symmetry, shape, texture, and color. And just to let you know that you need to remember that it's common for one breast to be slightly larger than the other. And for a lot of women, it's the left breast that's slightly larger than the right breast. The provider will inspect for any masses, retraction, dimpling, or ecchymosis present on either breast. Next, the provider is going to have the client place the hands on her hips and observe what things look like, then raise the arms over her head for axilla inspection. And then stand and place hands on hips and lean forward and observe. After that, the provider will assist the patient to a supine position with her head placed on a pillow or a folded towel and her arms resting above her head. And the reason why we rest the arm above her head is to help to spread the breasts out to make palpation easier. So we start with inspection and end with palpation. So the provider is going to use one of the 3 typical patterns to palpate the breast. They can use the spiral, pie-shaped wedge, or vertical strip method, and it's going to be performed on each breast. The provider will also gently compress the nipple between the thumb and index finger to evaluate for any masses and to check for any discharge, and this will also be performed on each breast. Provider will also palpate the axillary area for any tenderness or enlarged lymph nodes, and we'll repeat that with the patient sitting up on the edge of the exam table. So the provider will support the patient's arm, palpate downward from the armpit towards the ribs just below the breast, and that's performed bilaterally. There are so many instructional tools that can be used to give to a client and teach them about breast awareness and breast self-examination. The biggest thing that we should educate our clients about is being familiar with the normal consistency of both of their breasts and the underlying tissue. So that's why we really stress being breast aware, or that breast awareness all the time, not just performing it one time a month. Now, breast self-examination or BSE still involves inspection and palpation. So this little pamphlet that I added to this slide just gives a nice little explanation for a client to perform their own breast self-examination at home. Next up, pelvic examination. So pelvic examination is done to kind of check on how anatomically and what things look like in that vaginal area. It can be done by palpating through a vaginal exam, but it's oftentimes done in the clinic setting with a speculum, whether it is the disposable kind or the metal reusable kind that gets cleaned and autoclaved and repackaged for the next use. And speculums come in different sizes to fit the anatomy of the client appropriately so that we're not using one that's too big for a client. And a speculum will be used during a pap smear or papaniculo test that the provider will perform so that they can see where they're putting their instrument and get the correct sample from the cervix. So that's kind of what you're looking at right now between these three pictures is the provider getting ready to perform a papaniculo test or pap smear. And then the pictures in the middle and to the right of the slide just kind of shows kind of the process behind what's used, how it's done. So often, like the spatula or the broom instrument will be used, or a swab will be used, and some of that will go into or onto a slide so that it can be looked at under the microscope. And then the rest will go into a thin prep cup and sent off for evaluation for any abnormal cells. So again, there's different types of speculums for examinations and pap smears. And you can see those on the bottom right pictures. And then the top right shows pap smear equipment, including the thin prep bottle, the glass slide, jumbo swab broom, the different spatulas, and the cyto brush. The bottom left picture is a BBL culture swab, and in labor and delivery, we are taught to actually use this swab to perform a group B or group beta strep screening on a client when it's needed. So where we're swabbing the cervix and the rectum to be sent off to check for the presence of an overgrowth of group B strep. Now the top left picture shows urine, cervical, urethral, and vaginal swabs that can be used. These different types of swabs and probes are used for different needs. So, like they can use the yellow gin probe for urine to actually test for gonorrhea and chlamydia. So, just to kind of let you know. Now, this next picture shows the use of a speculum. And you have A and B, which is figure 3.4 in your book. And then you have this image that I got off the internet. and it technically come from the point. So it actually shows you, I think it's in your book as well, maybe figure 3.3, if I remember correctly. But so when you look at A and B on the right and compare what you see in the actual real life photo on the left, try to determine which little figure that it looks like. So I'll give you a hint. Image A is a nulliparous cervical os, meaning that this person's cervix has never been dilated. They've never had a vaginal delivery. It's their first pregnancy. Figure B is a parous cervical os, meaning they've had dilation and delivery through their cervix, a vaginal delivery. So now when you look at the actual picture on the left, which do you think it looks like? I'll give you a moment. It's actually B. So you have to kind of look at ignore the bright red around the center line, right there in the center of the cervix. The line almost looks whitish in color, but it's got some bright red around it. That oftentimes makes students think that it's actually A and not B, but it is a parous cervical os of a multipara female. So what that redness is you have to remember that our cervix is, especially when we're pregnant, it's friable, meaning that it's very tender and it will bleed easily. So for whatever reason, this client has just some irritation there, where it could have been from doing a pap smear or sexual intercourse or something. Contraceptive methods are next. Um, box 4.4 and table 4.4 are something that you're going to want to look at in your book. I am going to review just some failure rates with you. That's in one of the tables in your book. So if a client does nothing at all, they don't use any kind of contraceptive method whatsoever, the client or their partner, there's a failure rate of 85%, meaning that they have a high rate of getting pregnant. They got a 15% chance of not getting pregnant, though. Now, the fertility awareness-based methods, there's a failure rate of 25%. So that means that there's a 75% chance of not getting pregnant. Now, the withdrawal method, where the male withdraws before ejaculation occurs, or coitus interruptus, that has a failure rate of 22%. Imagine that. So you have a 22% chance of getting pregnant using the withdrawal method, meaning that you have a 78% chance of not getting pregnant, which is a much higher chance than doing nothing at all to not get pregnant. Then, of course, it just goes through the Lamb method, condom use for male and female, all the way through permanent sterilization. So when you get a chance, that's really interesting to look at in your book. Now let's review some of the contraceptive methods, and you need to understand these. So we're going to first talk about barrier methods. That includes the female condom, spermicide and contraceptive gel, male condom, diaphragm, sponge, and cervical cap. Now, you have to remember that um, you can pair spermicide and contraceptive gel with condom use to make it more effective for preventing pregnancy. And condom use is, other than abstinence, is going to be one of the few methods of actually preventing sexually transmitted infections during intercourse, whether it is oral, vaginal, or anal. Now, diaphragm sponge and cervical cap, we often pair this with spermicidal use. The biggest thing I want you to remember is that some of these can be applied several hours in advance, so that you're ready. And then you cannot remove them for a long period of time either, though. Otherwise, you subject yourself to pregnancy chances. So you need to look through your book and be aware of when you should insert and remove these, especially when it comes to diaphragm sponge and cervical cap. Now, hormonal methods can include an intrauterine device, or system. So there are several different kinds out there, including a copper IUD that has no hormones whatsoever, but it's still an intrauterine device. But Mirena is one of the biggest brands that's used. Birth control and morning after pills. You have progesterone only. You have the combi pills. Some are 28 days, and then you have basically a week of dummy sugar pills that they don't have any hormones in them, so that you'll have your cycle. Others work differently. You have a vaginal ring or the NuvaRing, Depo-Provera injection, implanted hormone like Implanon or Nexplanon, and then the patch like the Ortho-Evra patch. So again, these are hormonal. These are for biological female use, not for male use. Next, we have sterilization. And with sterilization, you can have female sterilization as well as male sterilization. So with that, I skipped it. I apologize. We look at bilateral tubal ligation, there we go, where they actually remove now a much larger portion of the fallopian tube to help decrease the chance of a post-tubal pregnancy or ectopic pregnancy. This is usually done, pretty much anytime after delivery. It can be done within hours after delivery or even weeks after delivery. It is considered a more permanent form of sterilization. And now that they take out a large portion of the fallopian tube, it is much harder to go back and reattach everything. So be aware of how the provider performs the procedure, so that if there's any chance in the future that you may want to reverse it, you can have that conversation with the provider. Now, as far as a vasectomy for the male goes, the male is going to have a much easier, shorter recovery time than the female. A vasectomy is done on an outpatient basis, typically in the clinic setting, where a tubal ligation is done outpatient in the hospital because the client will be either under sedation or have spinal or epidural analgesia. The male client getting a vasectomy is going to get it numbed up down there real good, and the provider will cut a portion of the tube that will interrupt the ability of sperm to go up to the and come out. So that as long as the male goes back to have the recheck to check for any little swimmers, and if they don't see any, then we know that the vasectomy procedure worked and it's good. But if not, then it may have to happen again. Now we're going to move on to pregnancy. And during pregnancy, we can use a couple of different methods for a estimated due date or estimated date of confinement, estimated date of delivery. They're all used interchangeably. So we can use a pregnancy wheel that you often see in labor and delivery, or even maybe you may have one or two stashed in the ER. We can use Nagel or Nagley's rule formula to calculate it, and ultrasound, which is the best method to obtain or verify a due date. So both the pregnancy wheel and the Nagel's rule, the accuracy of the due date is hinged on the birthing parent knowing the first day of their last menstrual period. Now, the one good thing about the pregnancy wheel is that, and I'll show you in a moment, is the fact that we can actually take that pregnancy wheel and adjust things to how many ever weeks they are. And we can backtrack to get a due date from there, or when was their likely their first day of their last menstrual period, things like that. Now, to get the baby's heart rate, that can be done by ultrasound, but we can also use a handheld Doppler or even an old-timey fetoscope, which you hardly see anymore on a labor and delivery unit. We're also checking the fundal height by measuring any time between 20 and 36 weeks gestation, using a measuring tape and checking the fundal height to see if it matches the due date that the patient has. So this is the pregnancy wheel. This is figure 12.3 in your book. And this wheel, it's got two parts to it so that you can twist it around to figure out where you need to go. So you move the wheel to where the arrow points on the first day of the last menstrual period. Then you can actually go by the month and day for the current date and figure out how many weeks they are, and also figure out their approximate date of delivery. Okay. This is Nagel or Nagley's rule. This is also calculating the estimated date of confinement or estimated date of delivery or due date. You need to know the client's first day of their last menstrual period. You need to subtract 3 months, then add 7 days, and add 1 year. And I like this little med comic that I included on here because it reminds you kind of with pictures and just a quick reminder that the NAGLE is 7 letters. So that's where you remember to add 7 days. Okay, so sometimes, like in a test, you might get a last menstrual period with just the month and the day. So February, we'll say February 14th. So if I'm going to subtract 3 months, we're going to go back February, January, December, November. So the due date's going to be November of the next year, the due date month, and then 14, we're going to add 7 days to that. So no, we're going to add 7 to 14 for the days. That should give us 21. So the due date will be November 21. Okay, November 21 of this same year, 2023. Or not, well, on my example goes as far back as 2023, but 2026 would be what it is. So February 14th, 2026, according to Nagel's rule, subtracting 3 months and adding 7 days, it's going to be November 21st, 2026. We're not going to add a year because when you count that, when you go backwards, you're going backwards a year to 2025. So if you add a year, that still makes it 2026. I hope that makes sense. Now, this is a picture with not only fetoscopes on it, but also the Doppler fetal heart rate monitor that we can use. For the Doppler fetal heart rate monitor, we have to put a water-based gel like KY jelly or something of that nature on the end of the Doppler that's going to go on the pregnant person's belly. And then you can perform Leopold's maneuver to find the baby's best place where you'd find the baby's heart rate and then place that over it. It's going to catch any sound it can. So it's going to get mom's heart rate or the birthing person's heart rate. So if you feel like that's not a baby heart rate, move it around. Sometimes we can even ask the client, where do they normally hear your heart rate for your baby? And they can actually point to it. And sometimes we can go straight there, and there it is. Now, these far right two pictures, you have the fetoscope that actually has the stethoscope ears to it. And then you actually have the old-timey Pinard fetoscope where that type, you actually put your ear on the end while you're pressing it into the mother's belly, and you let go of the fetoscope for that Pinard horn style one, and you listen. And if you're hearing the mother's heartbeat or you're not hearing the baby, then you need to move it around and try to find it. Now, Global Health Media is a website, globalhealthmedia.org. They have a ton of excellent videos when it comes to things all labor, delivery, breastfeeding, postpartum. So if you go to that website and you look at their videos and you narrow it down to maternity, you can actually look at some of their videos. Now, they are not in very well developed countries, but it makes you appreciate what we do have in our country when you look at the amount of items that they have to work with as midwives and nurses. This is figure 12.5 from your book, and this provider or a nurse, most likely with male arms and hands, it may be her actual provider, is performing the fundal height measurement. So the fundus is the top of the uterus, and this is where we typically, from gestation of 20 weeks to 36 weeks, measure to make sure that everything matches. The fundal height matches the gestation. Once the baby has grown and the fundus is at the umbilicus level, that is your 20 weeks gestation. And then as the actual pregnancy progresses, that fundus will rise up. The reason why we stop at 36 weeks gestation is because of how after that the baby can actually drop, or the mother experiences lightening where the baby's presenting part starts dropping down into the pelvis. So after 36 weeks, it's not really accurate. So that's why we only perform it between 20 and 36 weeks. So that's what this picture on the bottom left is actually showing you. Best to do with a measuring tape because that's going to be the most accurate. We can use our fingers, but this is prone to errors. So you'd use 2 fingers, which is approximately 4 centimeters, and 4 centimeters equals 4 weeks. So it's still, if you're out in the field and you're not sure what's, where things are, and they say, oh, I'm only 24 weeks, but I feel like I'm in labor, then you can put 2 fingers above the umbilicus, and if the top of the uterus is at that second finger at the top of that, then that's close to being, right there at 24 weeks. You go up 2 more fingers from that, 28 weeks. So now, if the fundal height varies by 2 centimeters or more from what we expect the measurement to be, we have to look at some things. Some causes potentially, like incorrect due date, slow or rapid fetal growth, abnormal amniotic fluid levels, poor maternal nutrition, molar pregnancy, or multiple gestation. So my last pregnancy, she was a big baby and she was big from the start, but we know my true gestation because I had serial blood work to check my HCG levels, and I actually saw her on ultrasound by happenstance, when we were playing with the new ultrasound machine our unit had got, um, I saw she looked like a little tiny bean in my uterus. And I was like, what is that? It was my baby. And I found that out the next week. So interesting to know. Um, so anyway, just remember we're measuring from the top of the pubic bone to the top of the uterus to assess the growth, determine gestational age, and confirm the due date. Pregnancy nutrition. Um, so this is table 11.5 in chapter 11, and it just talks about the different calories and protein, water, vitamins, and minerals that the non-pregnant, pregnant, and lactating client needs. And it just shows you the difference between each. So it's worth looking at and paying attention to. Um, we also used to really talk a lot about my plate and following dietary guidelines about eating a variety of foods from all food groups and using portion control, increasing their intake of vitamins, minerals, and fiber, lowering the intake of saturated fats, trans fats, and cholesterol. Make sure they're taking in adequate amounts of folic acid or folate from supplements or fortified food sources, increase the intake of fruits, vegetables, and whole grains, and balance caloric intake with appropriate exercise according to what they're used to doing to maintain their ideal body weight. And again, we know that our food guide pyramid has changed recently. While our book doesn't use the new guide yet, it goes by the old one and the old My Plate. By the time you go to take your NCLEX, it could actually be changed to the new food guide that was just instituted so this year. So be aware of that. What things should be avoided though in their diet when they're pregnant? So any fish with high levels of mercury like shark, swordfish, king mackerel, orange roughy, ahi tuna, and tilefish. And then any foods that could contain Listeria monocytogenes. So hot dogs and hot dog liquid, luncheon or deli meats, meat spreads, refrigerated pate, soft cheeses like brie, feta, camembert, and blue vein cheeses, refrigerated smoked seafood, and raw unpasteurized milk. Those are all well known to contain listeria. And listeria not only can make the mother quite sick, but it crosses the placenta and can cause great harm to the baby and even potential death. Now we are moving on to electronic fetal monitoring. So I like this picture from the book that's coming up, figure 14.5. This just shows you what continuous external fetal monitoring looks like. So at the top, that top strap with the monitor piece, that's the toco transducer or toco dynamometer. And the gray one here at the bottom of her belly is actually the ultrasound transducer. And then those are connected by wire to the brain of the monitoring device. And it's nice because this client's room actually has well, it's old-timey computer monitor, but a computer monitor. So the top left picture is the toco transducer or toco dynamometer. You can tell that's what it is because it's got this funny looking little circle within the circle. That circle is the pressure sensitive sensor that senses the change in pressure in the abdomen externally to actually show and trace contractions on the fetal monitor screen. The middle picture on the top is the ultrasound transducer, and it has just a single flat circle in the center of it, and it's what we put our ultrasound gel on, and put it on the mother's tummy in the best place to try to get the baby's fetal heart rate. And remember, with external monitoring, we have to palpate the client's abdomen to tell the strength of the contraction. Just because the contractions look strong on the fetal monitor strip does not mean that they actually palpate strong. So we have to palpate the abdomen. Now, the far right top picture is the latex-free belts. Now, some hospitals have like a belly band that goes up over the belly that is kind of sheer but stays in place and is more comfortable than these monitor belts. Other places don't have that. So it just depends on the facility. The bottom right picture is an intrauterine pressure catheter, or IUPC. A trained nurse or provider, depending on facility policy, upon the provider's orders, can insert this intrauterine pressure device into with the vaginal exam into where the baby's at, inside that amniotic sac area, where the actual tip of that sensor probe for the IUPC will go between the baby's shoulder and the uterus, so that when a contraction occurs, it actually tells the actual strength on the monitor system of the contraction. And we can literally count the strength with called Montevideo units over a 10-minute period to tell if labor is strong enough to be adequate or not strong enough and may need some augmentation. The picture beside the intrauterine pressure catheter is the actual monitor brain part, and it is multifunction because it actually not only does external monitoring, but it does internal monitoring. And some monitors have wireless monitors that can be used, not just wired monitors. It also is made to be able to get the blood pressure and heart rate and oxygen saturation on the birthing parent, as well as a quick EKG during labor if we needed to get that on the birthing parent by plugging in the correct monitor part and attaching the electrodes to the mother's chest. So it's multifunction. And it has settings so that we can set it to auto obtain and populate our vital signs results according to the minutes we want to set it to, the frequency. Now, the last two bottom left pictures is a fetal scalp electrode, or FSE. And if we are having trouble or the baby's heart rate does not seem to be doing well, the provider may order for a fetal scalp electrode to be placed by a well-trained nurse, or they may come in themselves to put it on. And if you can see in this picture with the greenish background, it's actually a little wire coil that gently gets screwed into the scalp. It only goes so far in, and it will leave a little mark on the baby's head, but that's how we get the accurate fetal heart rate on the baby. Now, if the baby has a lot of hair, sometimes it's hard for these to stay on if we didn't appropriately put it in place. Now, a fetal scalp electrode and an intrauterine pressure catheter requires the amniotic sac to be ruptured. Okay. We can't just put it on before ruptured membranes. It requires the patient to be ruptured already. So I love this little picture that I had found on the internet. And it just shows the intrauterine pressure catheter and the fetal scalp electrode inside the uterus. So this figure is a nice little figure to give you a visual of where things go. The intrauterine pressure catheter is not just a device that can only detect accurate pressure of the contractions. It also has some holes in it so that we can take a sample of amniotic fluid if we need to. We can actually infuse fluids in there with the baby if there's oligohydramnios or too little amniotic fluid, and do an amnio infusion to either help thin out very thick meconium stained fluid or give more cushion to the umbilical cord. So it's a multi-use tool that we have more than one use for. So we're going to do a quick overview of external fetal monitoring. And so if you will just hang with me while this video plays, it's very short.
Hi, this is Nurse Angela with Angela's Student Nurse Toolbox. I'm going to talk to you today about understanding fetal heart monitoring. If you are in maternity clinicals, uh, you want to have at least a basic knowledge of what you're looking at on the fetal monitor and know when to respond and how to respond. So, our first strip is some basics of fetal heart rate monitoring. So, you'll see in the blue highlighted area, that is the fetal heart rate. Normal fetal heart rate can be anywhere from 110 to 160s, 170s. You'll see that there's some rises and elevations in this heart rate. It's not a flat line. Okay, that's what we call variability. That is, it goes up and down and has movement to it. The bottom, you'll see these hills where the arrow's pointing. These are your contractions. They look like little mountains. With an external fetal monitor, it's just showing that they're having a contraction, not how strong they are. So let's look at the next slide. Baseline fetal heart rate. This is what the heart rate looks like average time between contractions. So if you look at this one, the number was 150. So most of the time, the heart rate's been in the 150s. So that would be your baseline fetal heart rate. That's important to know because if that changes, maybe something's going on with the baby. Accelerations. This shows that you have a happy baby. This one's pointing to an elevation of the heartbeat. It's going up. It's responding well to contracting at the bottom. You see the contractions. We want to see that as a healthy sign that everything's okay during labor. So you want to see some accelerations. And that's a rise in the heartbeat. Early decelerations. This is where it kind of dips when you have a contraction. So at your peak of your contraction, so the top of the hill, I have a little bitty indentation. It drops a little bit, the heart rate. Those are called early decelerations. That means the baby's starting to move on down, go in the right direction. Okay, so that's all that sign is. It's just moving on down. So maybe we're getting somewhere with our labor. So that's a positive sign. Variable decelerations, these are those highlighted big V's. It could be W shapes, V shapes, U shapes. This could mean that there's some cord compression. So baby could be playing with his umbilical cord. The cord can be getting compressed as the baby's moving on down in response to being squeezed with each contraction. We get concerned when they get really low, okay, and the baby is not ready to deliver yet. Sometimes this might happen after we break a water bag, um, and we might have to do a procedure called an amnio infusion where we have to hook up an internal uterine pressure catheter device, slide that into the uterus, and hook up some IV fluids, give some extra cush in the uterus so the baby's not up against the cord. And that's called an amnio infusion. Sometimes we have variable decelerations when mom's getting ready to push as she gets closer to delivery. And with every contraction, if I see a little bitty variable, that's a sign that maybe I need to go check mom, do a vaginal exam, and she's probably 10 centimeters and baby's ready to come out. So that's usually a sign, especially if moms have an epidural and they might not feel that pressure that the baby's right there. If the heart rate starts doing this with variables, with all the contractions, it's time to go check mom because she's probably ready to push. The next one are late decelerations. This is where you have the peak of the contraction. So you'll see where it's that contraction where it's in red, the peak of the contraction, so the top of that hill, the heart rate starts to drop. Okay, then it goes back to normal. Mom has another contraction and then it drops again. This is a sign of uteroplacental insufficiency. So that means the baby's not getting enough oxygen. It's not tolerating labor well. Sometimes when we have this, it might be if mom has Pitocin on, an IV drip to augment her labor. It might be too much. We might need to turn this off. We might need to turn mom on her left side and put oxygen on mom to help the baby to see if this gets better. Because if these continue, it might be a choice that we need to do a C-section. The next one, this is a very big late deceleration. If you look at these contractions at the bottom, each one of those lines where the blue arrows are is a minute. So it's a minute between each contraction. And look how close these contractions are. Normally we want contractions 2 minutes apart to be able to go and change somebody's cervix and dilate them. These contractions are one on top of another. They're too close, and that baby's getting squeezed and squeezed and squeezed with each contraction, but it's not letting up enough for that baby to breathe in, get a little bit more oxygen, get that heart rate back to normal. So this is called a prolonged late deceleration where it drops in the heart rate. So this heart rate actually drops down to the 50s. So this is a sign we need to get this baby out now. Okay. If mom was on Pitocin, I would be turning that drip off right now because those are called tetanic contractions because they're back to back and there's no rest for that baby to get oxygen. So this is called a late deceleration, and more than likely we would have to do an emergency C-section if we can't get rate up. I hope this helps you understand fetal heart rate monitoring. Subscribe and like my channel if you want to continue seeing more videos and access to whatever resources I can provide. Good luck.
I liked that video. Um, it was just a quick way to kind of talk with you quickly about um, what I'm getting ready to go into a lengthy conversation right now with you about. So when you look at a fetal monitor display, usually between the dark lines, it's a minute. So that means each square is 10 seconds. The fetal heart rate tracing is on the top section where, in this one particularly, where you have the blue shaded area, and the uterine contractions or uterine activity is displayed on the lower section. Now, some hospital units will actually provide their brand new nurses with some sort of EFM ruler that is transparent with writing on it so that they can determine what they need to call what they're looking at. Um, so that's just an example. One is the Miller Read Write EFM ruler, but there's several of them out there other than that one. The baseline fetal heart rate is the mean fetal heart rate rounded to the increment of 5 beats per minute during a 10-minute segment. This excludes any periodic or episodic changes, like any of the decelerations or acceleration, or periods of marked fetal heart rate variability. And you'll see why you can't get a baseline heart rate here soon when I show you that. And segments of baseline that differ more than 25 beats per minute. So the baseline fetal heart rate must be for a minimum of 2 minutes in any 10-minute segment. Okay. So the normal fetal heart rate baseline range should be between 110 and 160 beats per minute. And the baseline fetal heart rate is normally set by the atrial pacemaker of the heart. And the beat to beat differences in the heart rate are governed by a balance between the sympathetic and parasympathetic branches of the autonomic nervous system. So, as the central nervous system matures, the baseline fetal heart rate gradually drops. And the normal ranges for mid-trimester fetus are between 150 to 170. Now, as the gestational age advances, the parasympathetic tone becomes more dominant. So a post-term fetus may have a fetal heart rate that's between 110 and 120. Now we're going to talk about variability. Variability is the fluctuations in the fetal heart rate of 2 cycles per minute or greater in the baseline variability. Variability is usually quantitated as the amplitude of peak to trough in beats per minute. So it's those squiggly up and down lines that we see in the fetal heart rate tracing for the fetal heart rate. Absent means the amplitude range is undetectable. So you, in that 10-second frame, but you can't detect any amplitude range with it. Now, minimal, the amplitude range is detectable, but it's 5 beats per minute or fewer. So less than 5 beats variation around the baseline. So this minimal variability, this can be typically noted like if a baby's in the middle of a sleep cycle, for instance. So decreased or absent variability can represent some dysfunction in one or more systems or an increased and dominant tone of one system over the other. So like, again, sleep cycles or due to the effects of drugs. So causes of decreased or absent variability include hypoxemia or acidosis, fetal sleep cycles, maternal drug use like analgesics, barbiturates, tranquilizers, parasympatholytics, anesthetics, prematurity of the fetus, arrhythmias in the fetal heart rate, fetal tachycardia, pre-existing neurological abnormality in the fetus, and congenital anomalies in the fetus. Next up is moderate variability and marked variability. Moderate variability is that amplitude of 6 to 25 beats per minute in variation around the baseline heart rate. Now, it is what we like to see. Moderate variability is normal. It means that our fetus has good oxygenation status. Okay. Pair that with accelerations in the heart rate, and that really means more. It really, that's really good what we like to see. So it's like the picture to the left. But marked variability is where the amplitude exceeds 25 beats per minute in the fetal heart rate baseline. So this pattern, we sometimes hear it called a saltatory pattern. And you really can't get a true baseline heart rate out of this. Okay. Because does it fall down below, in the middle, up high? Where do we get it at? So we really, can't say a baseline heart rate with marked variability. Now, being a saltatory pattern, it suggests acute hypoxia or some sort of mechanical compression of the umbilical cord. And this is often seen during the second stage of labor. When coupled with decelerations in the fetal heart rate, this is considered non-reassuring and should warn the physician and the nurse to search for, correct any potential causes of hypoxia. So, what are some causes of increased or marked variability, or that saltatory pattern? Fetal stimulation, mild transient hypoxemia, and maternal drugs. Bradycardia in the fetal heart rate is exactly what bradycardia in the adult heart rate is. It's just a different amount. So with the fetal heart rate, the normal being 110 to 160 beats per minute, bradycardia is less than 110 beats per minute. And then tachycardia is like our tachycardia, but it has just a different fetal heart rate amount. So tachycardia is a fetal heart rate baseline greater than 160 beats per minute. Now, there are several causes of fetal tachycardia that must be considered, including maternal fever, chorioamnionitis, fetal sepsis, maternal drug use like Vistaril, beta sympathomimetics, fetal hypoxemia, tachyarrhythmias of the fetus, fetal heart failure, severe fetal anemia or fetal hydrops, and maternal hyperthyroidism. Now that we've talked about fetal heart rate baseline and variability, we're going to talk about our mnemonic that lets us know those periodic and episodic changes within the fetal heart rate. This mnemonic that you need to remember is VIL, CHOP, MINE. VIL is the fetal heart rate pattern that is seen. CHOP is the cause of that fetal heart rate pattern, and MINE is how you manage it. So the V in VIL signifies a variable deceleration in the fetal heart rate. It oftentimes looks like a V, a W, or a sharp U. It is an abrupt or sharp decrease in the fetal heart rate with an abrupt or sharp increase in the fetal heart rate back to its baseline. It's often accompanied by shoulders before and after. So at the beginning and end of the variable deceleration. And what I mean by shoulders is it looks like there's going to be an acceleration in the heart rate, but then it abruptly drops. Now, the cause of variable decelerations in CHOP. So C is cord compression. Somehow the cord's being compressed, and it doesn't have to be by a contraction either. Okay? Variable decelerations can happen with a contraction or independent of a contraction. So the baby could literally be holding on and squeezing the cord with no contractions present. Or the baby's moving and maybe the cord's wrapped around body parts. And so as it's moving, it compresses the umbilical cord, but it's cord compression. How do we manage cord compression that cause variable decelerations in the fetal heart rate? Well, that's the M in mine. We manage it with maternal repositioning. The E in VIL is for early deceleration. Early decelerations have a gradual drop in the fetal heart rate with a gradual return back to the fetal heart rate baseline. The drop in the fetal heart rate starts when a contraction starts. The lowest point of the fetal heart rate is at the highest point or peak of the contraction. And the fetal heart rate is back at the normal baseline when the contraction's over. The cause of early decelerations is the H in CHOP, which is head compression. Head compression generally or usually means the baby's actually dropping down more into the pelvis. Now, how do we manage head compression that's shown on the fetal heart tracing by early deceleration pattern? We do I, which is identify labor progress, in mine. So we're going to identify the labor progress. We might need to check the cervix. A is for acceleration in the fetal heart rate pattern in VIL. In CHOP, it's O. O meaning it's okay. It's good. We like to see it. It's okay. And N in mine is there's no interventions for it because it's a normal thing that we like to see. Normal, no interventions, okay? Now, L in VIL is late deceleration for the fetal heart rate pattern. A late deceleration is the contractions already started. By the peak of the contraction or the highest point of the contraction, the fetal heart rate starts to gradually drop. The lowest point of the fetal heart rate generally occurs at the end of the contraction or shortly thereafter. And the return of the fetal heart rate to baseline, it has a gradual drop and a gradual return to baseline, but that return to baseline occurs between contractions. Okay? Where an early deceleration mirrors the contraction, a late deceleration is offset from the contraction. Now, the cause in CHOP is P for placental insufficiency. That placenta is not getting enough oxygen and nutrients to the baby for whatever reason. Okay? And then how do we manage it? In mine, it's the E, we execute interventions. We are going to be performing our fetal resuscitation techniques, such as turning off oxytocin, repositioning the patient to the side or knee chest position, performing a vaginal exam, and possibly we're going to call the doctor to come and evaluate and possibly expedite a delivery. Also, now that we're post-pandemic, we've started back providing oxygen via a non-rebreather mask. So execute interventions for placental insufficiency that is shown on the fetal heart rate pattern on the monitor as late decelerations. So I would absolutely memorize this, understand it, and draw out what each of the fetal heart rate patterns look like beside each of the letters on my whiteboard if I'm in the middle of testing. Not before you're able to start your test, but after you start your test. Now, this picture comes from Osmosis back when I had a paid subscription with Osmosis. And I like it because it puts your early, late, and variable decelerations all on one page. It talks about the classification of them, the background and symptoms that the mother may have. So you can physically see what these look like with contractions at the bottom. Okay. So the top blue line indicates late decelerations, and you can see where they're off center because there's a blue dotted line going down through the middle of the contraction at the highest point or the peak of the contraction. The purple line in the center at the top is variable decelerations. Right now it's showing a W pattern. It can also be a sharp abrupt U or even a V pattern. And then the green line at the bottom on the fetal heart rate section is early decelerations. Okay. So let's start with variable deceleration. Variable deceleration is an abrupt, visually apparent decrease in the fetal heart rate below the baseline. From the onset of the start of the variable deceleration to the lowest point in the fetal heart rate, or nadir, is usually less than 30 seconds to get from when it starts down to the lowest point. Now, it will also decrease by 15 beats or more, and the duration should last at least 15 seconds or more, but no more than 2 minutes. So you can see the abrupt V with the shoulders, or the abrupt U with the single shoulder at the end. You can also see with this other one beside that. So remember, U, V, or W pattern, it can be in relation to the contraction or totally not related to the contraction at all. It often appears as though there's small accelerations immediately before and immediately following the deceleration, and we call those shoulders. And this occurs because of umbilical cord compression. Early decelerations in the fetal heart rate correspond to the contraction and exist as a periodic change. They are benign because they are caused by a vasovagal response of the fetus as a result of fetal head compression due to the contraction. So the pressure on the fetal skull alters the cerebral blood flow, and this in turn stimulates that vagus nerve. So that's why you see the gradual drop in the heart rate that mirrors the contraction. Okay. Now, again, it's associated with the uterine contraction. It's visually apparent with a gradual decrease in the fetal heart rate, where the onset of the deceleration to the lowest point or nadir of the fetal heart rate occurs in 30 seconds or more, with a return to baseline gradually as well. And the lowest point in the fetal heart rate, or the nadir, corresponds directly with the highest point or peak of the contraction. So that's why it's said to directly mirror the contraction. If we see this pattern in early labor, the client's 4, 5 centimeters, that's not a good sign because typically we see we like to see this when they're advanced dilated in that um, active phase of labor on through the second stage till the baby's delivered. So if it's found and if we see early decelerations early in labor during that latent phase, it can be associated with cephalopelvic disproportion or CPD. Baby's head and body's not going to fit through that smaller pelvis. Baby's too big. An acceleration in the fetal heart rate is a visually apparent increase in the fetal heart rate from the most recently calculated fetal heart rate baseline. The onset to the peak of the highest point in the fetal heart rate is less than 30 seconds. It should last greater than 15 seconds and be at least 15 or more beats above the fetal heart rate baseline. But it should be less than 2 minutes. Okay. Now, we can have such a thing as a prolonged acceleration that lasts 2 minutes, but less than 10 minutes. So as long as it lasts less than 10 minutes and goes back to its normal fetal heart rate baseline, we tend to be okay. But if it lasts longer than 10 minutes, it's a fetal heart rate baseline change. So it's no longer considered an acceleration. We like to see accelerations because that means that the baby's heart rate's appropriately responding to the baby's activity. And pair that with a moderate variability, and it lets us know that neurologically and oxygenation wise, the baby is doing well. Late deceleration. Late deceleration is periodic because it occurs in association with the uterine contraction. It's a visually apparent gradual decrease in the fetal heart rate with a gradual return to baseline. Now, from the onset of the decrease in the fetal heart rate to the lowest point or nadir of the fetal heart rate occurs in greater than or equal to 30 seconds. Now, as this right picture kind of shows you, it is offset with the contraction. It starts to go, the fetal heart rate starts to decrease at or after the peak of the contraction. The lowest point of the fetal heart rate is towards the end or shortly after the end of the contraction, and it's recovered to the fetal heart rate baseline well after the contraction's over during that resting phase between contractions. So a late deceleration is offset from the contraction, and it occurs because of uteroplacental or placental insufficiency. So in knowing that, we know that there may be a problem with uterine perfusion or uterine activity or with the placenta or all of the above. So any of those causes can eventually lead to fetal hypoxemia and myocardial depression if it occurs over a long period of time. A vasovagal reflex leads to cardiodeceleration, and continued hypoxemia can lead to lactic acidosis secondary to anaerobic metabolism. So causes of placental insufficiency are varied. Many are reversible. So some of the causes could include uterine hyperactivity, maternal hypotension, like shortly after they get an epidural, maternal hypertensive disorders, placental abruption, placenta previa, fetal intrauterine growth restriction, maternal diabetes, chorioamnionitis, postpartum gestation, maternal anemia, RH isoimmunization, maternal cardiac disease, and maternal smoking. Now, a prolonged deceleration is a visually apparent decrease in the fetal heart rate below the baseline, and it has to decrease in at least 15 beats per minute or more, and it needs to last at least 2 minutes or more, but less than 10 minutes from the onset to the return of the baseline. It can be caused by any mechanism which normally may lead to periodic or episodic decelerations, but the return to baseline is delayed because the stimulus or mechanism causing the deceleration is not reversed. We often associate prolonged decelerations with hypoxia. So we see this with cord compression, profound maternal hypotension or hypoxemia, tetanic uterine contractions, prolonged head compression associated with the second stage of labor. If we have a fetal heart rate above 100 beats per minute with moderate, good variability, having a single or maybe two prolonged decelerations, and that's all we have until delivery, might be able to be tolerated by the fetus. But if the fetal heart rate goes below 100 beats per minute, especially if the variability in the fetal heart rate is minimal or absent, that is not good. And that calls for immediate efforts at a resolution. And especially if the drop in the fetal heart rate is below 60. When it's below 60 beats per minute, it's an obstetric emergency. And it is almost always associated with fetal hypoxia. Okay. So this would cause us to perform intrauterine resuscitation techniques. So we treat the mother to treat the baby, provide oxygen via a non-rebreather mask at 10 liters of oxygen, turn her on her side or put her in knee chest, turn off the Pitocin if it's running, contact the provider after we've performed a vaginal exam and got the mother's vital signs, because the provider may need to come in and evaluate what's going on. And we may need to expedite a delivery, whether the mom is 10 centimeters or she's not and might need a C-section delivery. The last two slides I'm going to show you as far as fetal heart rate have to do with sinusoidal and pseudosinusoidal fetal heart rate patterns. A true sinusoidal fetal heart rate pattern is a regular, smooth, undulating fetal heart rate pattern. It's typical of a sine wave that occurs with the frequency of 2 to 5 cycles per minute and an amplitude range of 5 to 15 beats per minute. But what I want you to notice is there's no variability in this. There's no little squiggly or little teeth marks anywhere in that heart rate. A true sinusoidal fetal heart rate pattern is an emergency. We don't play around with this. That baby already has some sort of insult to show us this pattern. We're going to be calling the provider, doing intrauterine resuscitation techniques, and expediting a delivery. Now, a pseudo sinusoidal fetal heart rate pattern looks different. So it is not smooth and undulating. It has decreased regularity and it has some preserved beat to beat variability. So it's got like little teeth marks here and there. Now, this is a pseudo pattern. It mimics a sinusoidal pattern to an extent. But this is not an obstetric emergency. This is typically seen when that fetus is sucking their thumb. That's often when we see this. It's usually very brief when it occurs and it goes back to normal fetal heart rate pattern. Okay. Now, back years ago, I remember when the Association of Women's Health, Obstetric, and Neonatal Nurses, or A1, came up with this category of interpreting fetal heart rate patterns, the category system. And so we actually, I remember not ever having this before and having to learn to implement, use it, and document it. And of course, everybody fussed because it was new. But it is an easier way to interpret what we're seeing. It gives us guidelines and parameters to know what's normal versus what's indeterminate, meaning that the baby is, it doesn't say whether or not the baby is going to come out okay, but we've got to be aware and continue to monitor and may actually have to do some actions. But category 3 is absolutely abnormal. And category 3 is when we actually institute interventions, which is our intrauterine resuscitation techniques and possibly expediting a delivery, one way or the other. So you need to understand this, okay? It's table 14.1 in your book. Mine is pink, but in the 5th edition, because this is the 4th edition, yours is going to be that kind of weird, like blue gray, green shades that the 5th edition book has, but it says the same exact thing because this hasn't changed in all these years. Now, box 14.1 are interventions for category 3 heart rate patterns for the fetus. So we're going to notify the healthcare provider about the pattern and obtain further orders, making sure to document all interventions and their effect on the fetal heart rate pattern. If the client has oxytocin or any other uterotonic agents administered, then we are going to discontinue that or treat according to the facility's protocol and the provider's orders if it's being administered. We're going to turn the client to the left or the right lateral, the knee, chest, or hands and knees to attempt to increase placental perfusion. And if there's cord compression, relieve that cord compression. We give oxygen at 10 liters via a non-rebreather face mask to increase fetal oxygenation. We're going to give an IV fluid bolus to help improve intravascular volume. And if there's any maternal hypotension, it can help to start correcting that. We're going to assess the client for any underlying contributing causes. We're going to provide reassurance that the interventions that we're doing are to help affect the pattern change. So we treat mom to treat the fetus. If we are in the 2nd stage of labor and pushing, we're going to modify that pushing to improve fetal oxygenation between pushes. We document any and all interventions and any changes in the fetal heart rate pattern and prepare for potentially expediting a birth if the pattern's not corrected within about 30 minutes. So typically we talk about a surgical birth, but this could also mean that the head's far down enough that the provider might attempt to use a vacuum extractor or forceps to deliver the baby vaginally. Let's talk about contractions. So when we talk about contractions or uterine contractions, We have to talk about the different terms involved. So, tachysystole or polysystole is defined as 6 or more uterine contractions in 10 minutes without evidence of fetal distress. So, there's too many contractions. Hypertonus is either an abnormally high uterine resting tone or so greater than 25 millimeters of mercury, or Montevideo units greater than 400. Hyperstimulation is an archaic term that you will still hear today. Um, and it means either having persistent tachysystole um, with evidence fetal distress, like late decelerations or loss of variability. Um, but we can also see it being persistent without distress. A single uterine contraction lasting greater than 2 minutes, which is also called a tetanic contraction, or uterine contractions occurring within 1 minute of each other. The most common cause of having tachysystolic, polysystolic, or hypertonic contraction pattern is administration of prostaglandins or oxytocin. So you may see other contractions that are patterns that include paired contractions that are coupling or skewed contractions as well. So it's not impossible to see those. And when you look at the contractions on the monitor, you're going to see that again, between each dark line is a minute and each box is 10 seconds. And we're looking at several things with the contraction. We're looking at the frequency of the uterine contraction. So that's the start of one contraction to the start of another contraction. And this is measured in minutes. The duration of the contraction is the start of one contraction to the end of that same contraction. This is measured in seconds. And then the intensity of the contraction, if it's external monitoring, you have to palpate the abdomen through the contractions and tell whether it is mild, moderate, or strong. If it is intrauterine, then you need to actually palpate the abdomen or palpate the abdomen for external. The intrauterine will actually tell you the exact strength of the contraction, which we can quantitatively measure by calculating the Montevideo units. And so to calculate the Montevideo units with an intrauterine pressure catheter, we look at every contraction within a 10-minute period. So you have to look at from the resting tone between contractions and count up to the peak of the contraction. And you have actual amounts on the side here. So once you get all of your contractions in a 10-minute period, you get that count for each. You have to add that together to get your MVUs. So the Montevideo unit is the sum of the intensity of each contraction in a 10-minute period. Adequate uterine activity is having a contraction pattern that generates greater than 200 Montevideo units. Spontaneous labor can actually cause Montevideo units to be greater than 300 millimeters of mercury in more than 40% of women. Now, the baseline pressure or resting tone is the uterine pressure in millimeters of mercury between contractions. It's while the uterus is relaxed. So we need to know that as well, because a high resting tone or baseline tone could signify problems like a uterine abruption or a placental abruption. So if you have any questions, reach out to me. You know how. Otherwise, this is the end of our lecture on antepartum.